Hello, and thank you for joining the POCUS Certification Academy for today's POCUS Bytes webinar. We are now starting, so all lines have been muted. Please use the Q&A box for any questions or the chat box for comments you have throughout the webinar. Today's presentation will include a panel discussion, and then we'll have some time for questions and answers at the end. Before we begin, I would like to take a moment and invite you to visit our webinar page at www.pocus.org, where you can find all previously recorded webinars searchable by topic. I also invite you to attend our May webinar with the title of Find Free Fluid Fast, Intro to the EFAST Exam, occurring on May 18th at 12 p.m. Eastern Time. Additionally, the POCUS Certification Academy will be hosting the 2021 POCUS World Virtual Conference on September 17th and 18th. Attendee registration will be opening soon. Please visit our website for more details. Today's panel discussion topic is POCUS in Global Health, and our panel facilitator is Dr. Kevin Bergman. Dr. Bergman is the co-director of the Ultrasound and Global Health programs at the UCSF Contra Costa Family Medicine Residency and Global Health Fellowship, Associate Clinical Professor of the UCSF Department of Family and Community Medicine, and the co-founder of the Global Ultrasound Institute. He also co-founded World Altering Medicine, a nonprofit organization that provides medical and surgical care to rural patients in Malawi, where he has returned annually since his first visit in 2002. Dr. Bergman, thank you for facilitating our panel discussion today. I'll turn it over to you to introduce the panel.
Okay, thank you very much for that introduction. I really appreciate that. I'm gonna just screen share for a second here, and hopefully everybody can see this. I'm really honored to be here. I'm just so talk about these two topics of global health and ultrasound that are both near and dear to my heart and probably my two favorite things in medicine. So and today I hope that we're gonna, what I'd like to do is shine a light on kind of the critical role that ultrasound plays in global health context and kind of amplify some of the voices of frontline providers who are doing patient care every single day in these contexts. And we're going to do this by sharing cases and stories and lessons learned, and hopefully have a robust QA session afterwards. And most importantly, we're really honored to have just an all-star panel here today of clinicians and educators and and really leaders in global health. We've got Mpundu Makasa from Zambia. We got Kaya Belknap, who's from South Sudan, currently in Kenya. We've got Vincent Ndebwanimana from Rwanda, Nahreen Ahmed from the University of Pennsylvania and Med Global and Bridge to Health, and Erin Stratta from Doctors Without Borders. So we really just so delighted to have them here today, and I'm going to be turning it over to them in a couple of minutes, and we just really thank them for their time and their knowledge and expertise. And just kind of taking a step back for a second, I think the World Health Organization a couple of years ago came out with a statement that they said that basically every third or fourth patient that you're going to see anywhere worldwide is going to need something more than a history and physical. They're going to need some kind of diagnostic, either labs or imaging, in order to actually get to the correct diagnosis. And they also kind of dropped the unfortunate truth that 2/3 of the planet basically has virtually no access to that kind of diagnostic imaging. And I think that kind of like sort of sets the context for like those facts basically say that those who are working in a global health setting, there's this profound tension basically between the desire and effort to provide absolutely excellent patient care, but working within the very real constraints of limited resources in these contexts. So And I think that's what that brings us to POCUS and why it's really started to play a very indispensable role in global health. And kind of beyond the usual kind of everyday benefits of POCUS really anywhere, which evidence shows us that it rapidly narrows differential diagnoses. It makes for more successful and safer procedures, oftentimes giving you definitive diagnoses within minutes, and really kind of empowers you to take much more of take the diagnostic process more into your own hands and kind of become more self-sufficient. All those things kind of go double in global health. And there's additional factors as well, just the kind of general realities, the fact that the distances are long, the expense of transporting a patient or transferring a patient are often really onerous and sometimes not even truly possible. The cost of medications and hospitalization are also extremely difficult, and many times, sending somebody to a referral hospital for either definitive imaging or treatment, many of those facilities have really limited access to care and are quite overwhelmed with extremely sick patients. And they're just a heavy burden of disease and kind of the poverty that undergirds and underpins all of this reality. And another key factor is that, kind of like from the WHO statement about imaging, so like, even if you are at a place where there's an X-ray, for example, there are many contexts, there's frequent power outages, there's blackouts. So that means you obviously can't use an X-ray machine in that context. X-ray departments often have banker's hours. They're closed at 3 or 4. They're not open on the weekends. And as we know, sick patients come in at any time. CTs are often very rare, extremely expensive, and really just too far away. And so I think the portability, the versatility of POCUS shines so much, and especially when you've got a sick patient and you've got a time-sensitive diagnosis that needs to be made. It really shows its incredible value. And also just ultrasound in general, whether you're in any context, really often just gives you so much more than an X-ray does, particularly for lung and chest diagnoses that we're going to see in a couple minutes. It's been proven superior, for example, for the 4 major pulmonary pathologies. It's superior to a chest X-ray in sensitivity and specificity. And also with kind of further training and practice, you can really get to more advanced diagnoses with POCUS. So for all these reasons and more, people are really passionate about this. It is a game-changing tool, and it's the best empowerment tool that I've ever seen in global health. And I had kind of a deluge of thoughts and emails and WhatsApp messages and stuff from colleagues and friends who are working all around the world. And here are just a couple of their thoughts. Here's one: that there's not a single day that goes by where ultrasound doesn't change how I manage my patients. This is from a physician in rural Malawi. From a physician in rural India. In my rural setting, even when referral is possible, the ability to resolve more illness directly is so valuable, both to the patient and to the doctor. And lastly, POCUS not only makes the quality of my care better, it makes critical medical imaging and readily available to all of my patients, regardless of financial status, severity of illness, or the local X-ray machine working or not. And that's from a doctor, an educator in Zambia. So just to whet your appetite there, I think we're going to go right into our panel. And I'd like to introduce first Kaya Belknap. She is a wonderful physician, colleague, and friend. She grew up in South Sudan, was the physician in charge of the medical ward at St. Daniel Comboni Catholic Hospital, while South Sudan is now working in Kajabi Mission Hospital as a staff physician and educator there. So Dr. Belknap, why don't you take it away and screen share?
Hello, everyone. So nice to meet you all. Happy to be here talking about something that's so important to me. Let me share my screen. All right. So I have 2 cases to share with you today. And both of them illustrate exactly what Kevin just said, how important this is in making diagnoses rapidly without transferring a patient out, and really changes our management on a day-to-day basis. So the first case is a patient, 63-year-old male. He has a history of hypertension, diabetes, and CCF, and he presents to us with shortness of breath, cough, and weakness. He also endorses dyspnea on exertion, myalgias, and worsening dyspnea over the last 2 days. He denies fevers, but says that he has been sweating more than normal. He also ran out of his chronic CHF medications about a week ago. He denies any COVID-19 contacts. On physical exam, he does have some mild hypotension and tachycardia, but he's also pretty tachypnic and hypoxic. He's obese, he's not cyanotic, he's not jaundiced, he doesn't have any pallor. His lungs show increased work of breathing with bilateral crepitations and wheezing. His heart is tachy, but there's no murmurs. His abdomen's normal, and there is a moderate pitting edema bilaterally on his lower extremities. So we did get a random blood sugar that was 11.5, about 200 milligrams per deciliter. But unfortunately, the X-ray tech, as Kevin just mentioned, is out for the day and won't be available until the next morning. COVID-19 testing is also not available in our facility unless we transfer the patient to a different facility. And all other facilities in town are currently full due to our COVID pandemic. So, with only the history and physical exam, the differential is pretty wide. Given this patient's history, we most likely suspect a CHF exacerbation or COVID, given our current pandemic, but it also could be a PE, it could be an MI, it could be a COPD, it could be an arrhythmia, he could have another viral or bacterial pneumonia, he could have a pericardial effusion, the list is long. So what do we do immediately to manage him with the information we have? Should we diurese him or should we give him fluids? Should we treat him for ACS? Should we treat him for a PE? Should we put him in our COVID ward with other COVID patients and risk an already high-risk patient getting COVID if he doesn't already have it? Or should we transfer him? So we get out our trusty ultrasound and we have some images here. His lungs show B lines, but not B lines on their own, but confluent B lines. Some pleural thickening and some subpleural consolidations. I think you can see that here. Oh, sorry. Oh, this is even better. There's some videos of the same. So this shows confluent B lines. Play that again with subpleural consolidations and pleural thickening. This one shows about the same thing. You can see a skip lesion here. And here we can see a better skip lesion. Right there. We also did a quick echo on the patient. You can see that the EF is depressed, but when we took a look at his IVC was collapsible. So, grabbing this ultrasound and doing those quick images really give us a good picture of where the patient's at. Now we have a picture of a more septic patient rather than a CHF overloaded patient. So we put the patient in the COVID-19 isolation ward and started him on COVID-19 protocol. After a few days of treatment, we repeated the POCUS, and that showed that the IVC was now more plethoric and there were more diffuse B lines. So we started him judiciously on some diuretics as well. Ultimately, the patient did well and went home. And, maybe a week or so later. Okay, so that's one patient that ultrasound made a big difference in. Here's another patient also with dyspnea. This patient is a younger 37-year-old male with no past medical history. He presented with 2 months of dry cough, subjective fevers, headaches, myalgias, arthralgias, and loss of appetite. About a week ago, he started to worsen and now has dyspnea on exertion. He'd been to multiple clinics, multiple hospitals, and taken multiple courses of antibiotics and antimalarials and had not had any improvement. He denied any sick contacts and he works in construction. On exam, the vitals are pretty normal. On the physical exam, he appears maybe mildly ill appearing. He's not in respiratory distress. He's not jaundiced. He doesn't have cyanosis, pallor, or edema. He's not cachectic. His chest is clear. His heart's regular. His abdomen soft. No hepatosplenomegaly. The labs that we have available for him are a point of care hemoglobin and a random blood sugar, both are normal. We did a rapid malaria, that was negative. And again, unfortunately, the X-ray machine is now broken. So the differential for this patient is also very wide. Could be bronchitis, pneumonia, rheumatic fever, malaria, TB, could have a parasitic infection, HIV, where to start. So we did some images for him. And here on his abdominal ultrasound, we saw splenic microabscesses, as well as abdominal lymphadenopathy. So these are the splenic microabscesses here. And here's the abdominal lymphadenopathy. There's the spine. Anyway, I'm sure you guys know all that already. And then here's a video showing the abdominal lymphadenopathy and a video showing pleural effusions. He also had pleural effusions. This video is showing quite a large pleural effusions. His were bilateral and very small. Oh, sorry. So again, another patient where POCUS made a huge difference. So as soon as we got the ultrasound, then we were more suspicious of extrapulmonary TB. So we sent the patient to the government hospital, and where he got a HIV test and a sputum microscopy. HIV was positive, sputum was negative. So he came back to us, he was started on RIPE therapy, and then 6 weeks later was started on ARTs. He ultimately did very well, and we repeated the ultrasound and it showed improvement in all of those findings. So in both cases, POCUS made a huge difference in our ability to accurately diagnose the patient and then appropriately treat him in a setting where there was access to little else. The first patient likely would have decompensated and maybe even died had we started him on CHF treatment. And the second patient probably would have continued to worsen and gotten more cachectic with obvious signs of TB and HIV on clinical exam before getting the appropriate treatment. So those are the two cases I had to share with you.
Thank you so much, Kaya. Those are really dramatic, incredible cases. Really appreciate you sharing those with us. By the way, if you guys have questions about any of those, you can put those in the QA area or even in the chat, but I think prefer in the QA, and we can hit it at the end of the session. So I think, thank you for sharing. I'm going to go to Mpundu Makasa next from Zambia. She is MD, MPH, PhD. She's the third-year family medicine registrar there, Department of Family Medicine at the University of Zambia, and the School of Public Health, where she had a PhD in epidemiology in Lusaka. So we're really delighted that she's gonna she's with us today and gonna share cases. So why don't I think, Mpundu, I'm gonna screen share and you're gonna talk, right? So if I can go ahead and do let's see, I'll stop that. All right. Okay, go right ahead.
Okay, thank you so much, Kevin, and I'm happy to be here. So I'll be presenting two cases. The first case is a 26-year-old male patient who presented to our casualty department with a history of cough, intermittent chest pain, and dyspnea on exertion. So a chest X-ray was done and it showed a cardiomegaly, and an impression of coronary artery disease was made, and the patient was put on baby aspirin, a beta blocker, and a statin. He was later referred to a medical clinic for second opinion, and we decided to investigate him for TB. We also went on to perform a POCUS echo in particular, and it showed a large pericardial effusion. And so this is what we're seeing in this slide, which is actually the plaques view. And we're actually seeing a large pericardial effusion and anterior to the descending thoracic aorta. The next slide, that is the parasternal short axis view, also the same patient, and also showing the large pericardial effusion. Yeah, so from that, we're actually able to use the point of care. We're able to use the POCUS, and we're able to immediately detect pericardial effusion on the patient. We went on to order further laboratory investigations. However, given our high clinical suspicion, we initiated the patient on empirical antituberculous therapy. On follow-up visits, we use ultrasound-guided POCUS, and we're able to perform pericardiocentesis, and this actually gave the patient some symptomatic relief. We move on to the next. And then our second case, this was a 30-year-old male patient with a new diagnosis of HIV. So this patient was admitted 2 weeks after initiation of his antiretrovirals. So he presented to our clinic with a history of worsening abdominal pain, diarrhea, nausea and vomiting with associated fever. He was treated for acute gastroenteritis with dehydration, and he was started on antibiotics as we're querying an infectious cause. However, there was no improvement after the course of antibiotics. So we went on to perform a FASH scan, which came out positive. And so these are actually the pictures for the patient. So in the first slide, we actually saw the previous slide, that was actually a still picture in transverse view of the epigastric area, and we're actually able to see some hyperechoic structures. So to confirm what we are seeing in this, we went on to put Doppler, and we could actually see in the next slide, we can actually see that there's flow in the aorta and in the IVC. However, the structures around, we can see that there is no flow. So confirming that these were actually para-aortic lymph nodes. Next slide, please. Yeah, so we also did a pelvic scan, and we actually see that we see this huge anechoic area, which is actually ascites in the pelvic area. Next slide. Yeah, so given those findings, we're able to confirm a positive PASH scan, and therefore we concluded that the patient actually had abdominal TB iris, and we initiated his antituberculous therapy. And soon after, we actually saw that his abdominal symptoms began to improve. We later discharged the patient on his ARVs and ATT, and is currently being followed up as an outpatient. Okay, thank you.
Excellent. Thank you so much for sharing those cases as well. They were like that first case, oh my gosh, like 20 years old. And you did it sounds like a total 180 from what you're originally thinking after you put the probe on the patient's chest and saw that he had a huge pericardial effusion. That's a fairly dramatic management change. So it sounds like he's a bit of a clinical mystery so far. So we'll stay tuned for what the results are for that particular case. But thank you so much for those. I think we'll now go on to Dr. Vincent Ndebwanimana from Kigali, Rwanda. He's an emergency medicine physician and a critical care physician. He's the head of the A&E department there at the teaching hospital in Kigali, Chuck Hospital, and he's the program director of the EM critical care there at the University of Rwanda. And he's also the head of the Rwanda Tele-Ultrasound program, or the coordinator for that program. So really delighted to have Vincent with us here today. Vincent, are you able to screen share from Rwanda for us?
Good afternoon. I'm going to present a POCUS practice and the training in Rwanda. My name is Ndebwanimana Vincent. I'm the emergency physician and the ultrasound faculty in Rwanda. working at the Kigali University Teaching Hospital. I'm going to join this webinar starting with a case. 33 years old female who has been complaining of abdominal pain since August 2020, and she has consulted district hospital and also referred to referral hospital for upper GI endoscopy as requested by the district hospital, where she has diagnosed by the peptic ulcer disease with the treatment which has been initiated. Later on, she persists with the abdominal pain and she was diagnosed with hypertension until she got referred to referral hospital again through the emergency department. And as a childbearing, the first investigation to be done was a pregnancy test, which was negative. But also routinely, we had to do the point of care ultrasound, where we have to focus on OBS and gyne, but also liver and spleen and kidney. And most of the time, people pretend to forget the AAA. And this was the finding which was found during the scan of the AAA. And you can see the Doppler as well. And the next slide, you can see the still image where we found the mass at the aorta, which was measuring 6.17 out of 60 centimeters roughly. And it was diagnosed to be aneurysm. But also when you're doing a POCUS, you don't limit yourself to a single finding. We had to extend our scanning to the kidney, and we found that the kidney was atrophied compared to the left one. So, and we have confirmed it to the AAA, which was intra-abdominal at the descending aorta, and with suspicion of the renal artery being affected, as it has been confirmed by the CT scan later on. Coming to the trainings, the point of care ultrasound is the only solution to overcome the scarcity of radiologists, at least in our setting, but also in similar settings of lower middle income countries. And to achieve that, collaborative effort is necessary, where we start the collaboration with PUA programs, US-based initiatives to train the district hospital providers, and later on joining the residents to be able to train TOTs of future POCUS trainers. So far, the global collaboration for POCUS, which has been initiated, the PUA collaborative effort, HRIH Human Resource for Health, which has been supported by our Minister of Health. And through this, we have been able to train the trainer of trainers of point of care ultrasound and capacity building of the rest of the providers countrywide. Part of the innovative approach we use is tele-ultrasound mentorship, where we use handheld device like this one called React to connect with global POCUS providers to be mentoring the local providers. So not only that, we use the social media to discuss with other providers on the possible cases. You can see like on the left side, the chest X-ray, which was in favor of the bladder effusion, and the providers wanted to do the chest tube. But after doing the POCUS, we realized that it was a separated effusion where the chest tube would not help. Other efforts also included the emergency medicine in tropicals and also organizing the session during international conference. You can see on the right side where we're interacting with the AFCEM, African Federation for Conference for Emergency Medicine, which was held in Rwanda back in 2018. As a conclusion, point of care ultrasound is the integral part of the emergency medicine development, and the utility of POCUS is unlimited. you can be able to narrow the life-threatening condition which presented by an undifferentiated patient in emergency department. So thank you very much. I thank you for your kind attention, and you look forward to have more fruitful discussion. Thank you.
Thank you so much for that, Vincent. That was an incredible case. Some of you may be surprised in a AAA and a younger female, but that's actually fairly common in counterpoint to the presentations we have in North America and Europe. More often female and more often younger. So really incredible case there. And it's amazing the work that you're doing with tele-ultrasound and mentorship in Rwanda. Thank you so much. Next, we'll go to Dr. Nahreen Ahmed. She's assistant professor of clinical medicine, the Division of Pulmonary and Critical Care. She's also head of ultrasound for Med Global and Bridge to Health. She's also founded the Bangladesh Ultrasound Initiative and has done a variety of incredible things with ultrasound training all around the world, Yemen, Bangladesh, and refugee camps. And she's going to give us a couple of cases today. Nahreen, thank you so much for being here.
Thank you so much for having. I'm super pumped to be with this incredible powerhouse of people. So I'm just going to get right to it. If you have any issues, see my slide. So I'll start with the first case. It's a little bit of a different, direction, and hopefully this sparks some discussion. There's an emergency room in Mwanza, Tanzania. We had a 60-year-old woman presenting with prior history of colorectal cancer. She was previously treated with an unclear regimen. She was unable to tell us, but she did get some prior treatment. She presented with diffuse abdominal pain, but mostly located in the right upper quadrant. She had ongoing weight loss, diarrhea for weeks. She was afebrile, said absolutely no fevers, no chills, but she was definitely loss of appetite over several weeks. She was hypotensive on exam and afebrile on exam. Ideally, we would have wanted to get a CT scan of her abdomen, but given the circumstances, there was no CT scanner that was available at the time. The POCUS exam that we included, given her hypotension, we really wanted to focus on a few things, understand why she's hypotensive, thinking it's probably hypovolemia. Cardiac ultrasound showed a hyperdynamic LV. Her IVC was very flat. Her lung ultrasound showed A lines throughout, and then the EFAST, which was done just in case there was concern for bleeding, but also to include the abdomen as well, given that her pain was, showed the following. I'm not sure that, sorry. There we go. But what you're seeing here are several well-circumscribed lesions in the liver. And at the time, the discussion with the patient was really the following. So, the question here was, one, why is she hypotensive? Probably the diarrhea. We were able to tank her up with some fluids, give her some volume back, and that resolved. But then the bigger discussion was, what was the cause of her abdominal pain? And the thing that we saw here was it was likely metastatic liver lesions from her original colorectal cancer. This then led to a conversation with the patient. So how did POCUS guide management here? Didn't give us an intervention that could necessarily save the patient, which I think is often what we're always trying to do, but it did allow us to have a conversation with the patient about end of life, about goals of care. And so the primary team was able to guide the patient towards a palliative approach, which she was very open because she wanted to spend the time, the time that she had left with her family, and really not remain in a hospital for further tests and treatments that she felt she couldn't afford and that she felt would actually make her sicker. And in the discussion, I think that she was probably right about that. It really shed light on the importance of POCUS as adding early diagnostics in areas where we're unable to get imaging that may aid in minimizing the utilization of resources that would hinder quality of life, especially in this particular situation. And again, really, I think POCUS here just led to an open goals of care conversation, which is often something that's quite challenging to have, especially in resource limited areas. The next case I'll share is very different from the prior, and the site for this one was in the Rohingya refugee camp in Kutupalong in Cox's Bazar, Bangladesh. This was a 72-year-old female that presented to the clinic, and what you're seeing here on the picture to the left is the acute care area of a primary care clinic that's located deep in the camp. The patient came in with feeling short of breath. She was unable to really differentiate when we asked her about things like orthopnea. She didn't have any lower extremity edema, but she said, you know, I sleep on a mat. It's really hard for me to tell if I'm just uncomfortable from my poor sleeping arrangements. And so a little bit challenging to get a history. When asked about fevers, she endorsed them, but often in the translation, from what I've learned from some of the Rohingya translators that work with us, is that often the word fever is also how to describe feeling unwell. So the history itself was a little challenging to help us understand what was the etiology that we're dealing with here for her shortness of breath. She was afebrile, heart rate in the 80s, blood pressure 145/85, respiratory rate was a little high at 28, and she looked a bit uncomfortable, and she was hypoxic on room air at 85%. She had some crackles at the base and a faint wheeze. We do have oxygen cylinders there, so we were able to put her on supplemental oxygen, and we do have nebulizers there, so we were able to do that. Fortunately, we also have a stock of pharmaceuticals there, which include things like antibiotics, Lasix. We're able to place IVs, but there's absolutely no imaging available. You would actually have to transfer out of the camp in order to get an X-ray, believe it or not, because the camp itself is in the clinic. I mean, the clinic itself is in the camp. And so when we did our ultrasound, these were the images that we saw. And I left out the IVC image because I actually couldn't find it in my ultrasound library from this particular case, but what you can see is B-lines as well as LV dysfunction that you're seeing here on the right in a parasternal long axis view. These are just samples because I think it's a little bit easier to understand what's happening if you just see these in the context of what's going on. These B-lines were seen all across bilateral lung fields, and she had very trace pleural effusions as well bilaterally. So how did POCUS guide management in this situation? What we understood from what we saw in the story that we heard from the patient was that this is likely cardiogenic pulmonary edema. And it created a clear pathway to de-escalate the level of acuity of the patient, because we had a way to treat and monitor. And she came in on the earlier side of the day. She was given several rounds of diuresis. She had great urine output. Her respiratory rate came down. Her O2 needs were weaned over the course of the day. And she actually was able to say that she could come back the following day for follow-up. We successfully avoided a transfer by what we lovingly refer to as a bambulance, which is when the patient, as you can see here in the image, several of community members actually help. The patient is in a blanket that you see here, this gray blanket that's basically tied on either end to a large bamboo. And that is how patients are transported from the camp, which is in the clinic, to the area where they can get into a car and get transported to a field hospital or a higher level of care. This, as you can imagine, is a very labor-intensive and resource-intensive way to transfer a patient. And so in being able to identify something that's treatable where we are in the clinic, is a huge, huge help. And so I think that's an incredible resource to have in a place like this. And that's my last case. Thank you.
Excellent. Thank you so much. Those were really amazing cases and really brought home the power of POCUS in terms of understanding the etiology of someone's hypotension. In the case of the first one, undifferentiated abdominal pain, which turned out to be, to necessitate like a really great goals of care discussion and better resource utilization. Of course, in speaking of resource utilization, like being able to not transfer somebody in a setting like that in the Rohingya refugee camp. And I think it just underscores what happens when you empower a frontline provider as much as possible with POCUS and allow them to make the best decision possible. And often there's manifold downstream effects, impacts on patient care and on also the provider. So thank you so much for sharing that. We're gonna go to our last panelist now, who's Dr. Erin Strata. She is family medicine trained, global health fellowship trained as well. A friend and a colleague, she joined MSF in 2017 to develop their POCUS program and is now the project coordinator for their worldwide POCUS program and has grown it. It's extremely successful and it's used in many of their projects in over 70 countries. So we're really delighted to have Erin here today. Take it away.
Thanks so much. Let me make sure I can share my screen. I'm just going to try to round it out in less than 5 minutes. Kevin, are you guys able to see that?
Yes.
Okay, great. Yeah, so I was asked to speak just about a few of the kind of more global considerations of when you're trying to implement POCUS in a variety of different settings. As Kevin mentioned, we're a really big program. We have 65,000 employees, more than 140 projects. In the last 2 years, we've done 70 different POCUS trainings and more than 40 different projects. We have about 700 staff trained, and the majority of those are from the countries we work in, and half of those are mid-level providers. So we believe really strongly in empowering mid-level providers and not just specialty physicians. And as several of my other colleagues today have mentioned, you need to have a training of facilitators program as part of this to build sustainability from day one. Your leaders are going to be local, and any reliance on bringing in leaders from the outside is an antiquated idea. These are smart clinicians. They just need to be enabled with the technology. I think one thing that I can share across the board is an importance of a needs assessment. Every single project is unique. Each person that's spoken here today is speaking about a project in a specific context setting, cultural environment, referral milieu. Everything is different, and all of that needs to be thought about ahead of time. It usually takes us 3 to 9 months prior to implementing a point of care ultrasound training program in a site to really assess all of the different needs in that site, the morbidity and mortality, the scope of the providers and what they do, how this may impact their workflow, how this may impact the cost of the project and the number of referrals, how the other area radiologists or sonologists may feel about us doing this in this area. And so really the implementation of POCUS has to be tailored to your specific hospital, academic center, clinic in a refugee camp or project site. And that goes along with what you teach. And that actually needs to be different, I would argue, everywhere that you go. We're going to teach something different in a maternity project for midwives in Bangladesh than we are in a COVID home-based care project in Italy. And all of that needs to kind of be taken into account. And as previously mentioned, sustainability and longitudinal plans need to start before you actually decide to go in. I was also asked to speak a little bit about equipment because that's usually a common question. I think a lot of the people on this panel would probably agree, environmental factors are huge. Where are you practicing? How warm is it? How humid is it? How dusty is it? How capable is your electricity? Is it generator powered? Do you have some sort of universal protector system? What happens during a surge? All of that takes into account a lot about when you're going to invest in equipment. For many global programs, the biggest investment is this piece of equipment. And it's not so simple as we'll just buy another one when it breaks. This is really a 10-year life cycle timeline. This is an investment that we need to last for almost a decade. What's the warranty going to be on the product? If it breaks, where does it have to go to get fixed? How easy is that? Are there laws in your country which may prevent you from buying certain types of equipment? Certainly in countries like India, there are a variety of laws in place with good intentions to avoid female infanticide and things like that, but that makes buying certain types of ultrasound equipment much more difficult. How many users are you going to have? The types of probes that you may need depending on, are you treating neonatal patients or are you treating pregnant patients? A lot of ultrasound companies will offer you the opportunity to trial some version. Our theory has always been ask. If they say no, at least you asked. But a lot of these companies are willing to let you take one of their loaners to the machine for a certain period of time to see if it's a fit for you. But I would say in general, our goal is durability. And that's been the most important thing about ultrasound machines for us. We often get asked which applications are the most useful. That completely depends on the project. And I think everyone here would say the same thing. I would say the most common things that we teach in a non-maternity setting are EFAST, including FAST for non-trauma, pulmonary, cardiac, and soft tissue. We also include fracture detection in that because a lot of our sites don't have X-ray capability and do see a lot of fractures. And then more specific populations, as Kaya and some others mentioned, the FASH, the exam for TB and HIV patients, obstetric, especially for midwives and mid-level providers, and then procedural, depending on their scope of practice. The strategy in terms of implementation, this could be talked about ad nauseum, but in general, you want less people to the machine. So as many machines as possible. We try to have less than 4 learners to a machine. And we try to do a maximum of 60 hours, which is about 2 full days per week for a month, that our learners are in the ward scanning actual patients with pathology. This is not a classroom-based learning. This is all field and ward-based. And it's essential that your POCUS trainer is also an amazing clinician. It's just as important to teach good clinical skills along with POCUS. As everybody's cases kind of brought out, you need to be a good clinician, have a good sense of your differential diagnosis before you even pick up that probe. And then standards in terms of quality assurance, monitoring, and evaluation are really important. Somebody on the chat mentioned things about how do you get them extra help? We have a telemedicine platform and program. You're correct that lack of internet is one of the biggest obstacles to that. And I think the technology that exists needs to adjust so that it can work at low bandwidth for us. I think we've all had the experience where we just switched to WhatsApp and tried to send a video on WhatsApp because these fancier telemedicine real-time programs require too high of a bandwidth. And then lastly, I'll just mention quickly, before you implement POCUS, you really need to have some conversations with your administrators, supervisors, and hospital project on how this is going to impact the overall project. It's not always a completely happy impact that's positive and everyone feels good about. Your clinical staff may feel that they have more pressure to perform scans. As I mentioned, there may be more costs related to more referrals. It's still maybe providing better care, but to your finance committee, that may seem like a bigger cost. How are you going to handle misdiagnosis or malpractice? What's your relationship with the area imaging specialist? Are they going to be threatened by you? And how do you, approach that conversation? A lot of you probably work with Ministry of Health, or you at least have to liaise with them. So how do you work with the kind of other local actors? If they're handling TB care and you're diagnosing more extrapulmonary TB, you've got an issue there. And then longitudinal leadership is key to the program. That's just kind of a brief thing on some big things that we think about when we're integrating point of care ultrasound. Stop sharing my screen.
Thank you so much. Those are incredible pearls of wisdom there, Dr. Strata, and lessons learned from the field, from all around the world, from MSF. And thanks for sharing all that wisdom and knowledge. And kind of on the topic of training and learning point of care ultrasound, you touched on a lot of really important points there. We've had a couple of questions in the chat, and I would urge you guys, if you have questions, put them in the chat or in the Q&A, so we can get to them. We got a few moments for a Q&A before we sign off. One of the questions was, what would you recommend for me for starting to learn point of care ultrasound? What's the best way for me to go about to do that? I would pose that to anybody in the panel who wants to take that up.
Thank you very much. I'm Dr. Vincent responding. I would advise it to people who are willing to start a point of care ultrasound that initiating initial collaborative effort is really important, because that is through it where you can link, you can train TOTs, which means trainers of trainers who are going to sustain the program. From that, the program can run longer compared to the methodology of having a visiting faculty only coming to teach ultrasound. Apart from that, it's kind of culture changing. People has been used to consider ultrasound only from radiologist reports. So having people who can perform point of care ultrasound on themselves and still make an impact on patient or decision on patient care, it requires people to understand the capability and the utility of a point of care ultrasound, and that doesn't take long because people will learn through practice. Let's say if you diagnose AAA and calling a surgeon when they come in, they will say, no, this has been done by Vincent. Let's involve radiologists who are going to report the same thing. From that, they will understand that there is existing of this application, simple application, I would call it, which can be acquired skills among all of practitioners. Thank you. That is what I can comment on that.
Thank you, Vincent. Dr. Belknap or Ahmed, any thoughts on this one?
Yeah, so I think there are a couple different levels to this. For those that are interested in learning point of care ultrasound, there are definitely a lot of really good, high quality, free, open source, sites available. 5-Minute Sono is one of my favorites. That's a really great. EM Core Ultrasound is another one that kind of fits under that. I think it's the same group. That's a great way to just introduce the concept, kind of learn about it, and understand what point of care ultrasound is. But I think the next level beyond that is if you want to learn to use it practically, clinically. I agree with Dr. Vincent. I do think that there is a really big importance of that hands-on training, having that one-on-one training with a clinician that's an expert in POCUS, and really trying to find those in-country experts. And that's really, I find to be a big limitation, because I think there are in many countries, there are in-country experts, but to create that community where we all know about each other and who's practicing where and what is some person's expertise in one country versus another. But definitely when we implement these projects, especially for the organizations I work with as well, we're always trying to recruit in-country and local expertise as well to really improve the leadership of the POCUS program as it moves forward. And so that's another way to really start to see and ask around. It could be a radiologist, it could be a cardiologist. Many of us come from different medical backgrounds: emergency medicine, internal medicine, critical care, family medicine. There's so many different ways and different backgrounds that we come from and come into POCUS. But oftentimes in many countries, you might find a radiologist that can be helpful with ultrasound learning. You might talk to a cardiologist to help with cardiac ultrasound. With some of our organizations that maybe aren't in your country, that's what I would say is the best way to reach out to your in-country and local expertise to kind of learn some of the more focused exams.
Thank you for that. Thank you so much. Dr. Belknap, any other thoughts on that one? Yeah. So
practice.
Practice. Yes. And other question that came up was in terms of getting feedback on your scans. If you're learning, the question was, how do I know if I'm doing it right? Or how do I know if I'm making the proper diagnosis? What's the best way that you guys have found, or how would you advise people who are working not in a larger program, but kind of more individually or independently, how they can get feedback on their scans to improve their confidence and their competency?
There's sort of an old school method and a newer method. So the newer, fancier technology, the artificial intelligence, has built-in tutorials that will even feed back to you, rotate your hand, look down a little bit. But most of us don't have access to that fancy technology. And it's on us, it's on all of us to pressure these companies to provide more cheap or free and more accessible artificial intelligence. This should not be available only to high resource countries. The more pressure we put on these companies and organizations, it should be free, it should be open access, the more they are going to start to listen. But there is still a level of resistance right now. So the old school method is figure out what access you have to get images off of your ultrasound machine. And that's different in every single type of machine. A lot of the old ones have a USB port, and the vast majority of our students use a USB, they plug it into the machine, they download it, and then we do a snail mail method of reviewing their images. So they put it on a laptop, they put it online. I mean, yes, it takes a lot of steps, But this is what we're stuck with because a lot of our sites have older technology. There are free open access image review websites now. I think it's called Sono ClipShare. Our organization doesn't use that for data protection reasons, but that is a very popular one where you are able to upload your images to a website and you can have someone in another part of the world review and give you feedback on them.
Excellent, very important. Vincent, there was a question that came up about your tele-ultrasound mentorship. Could you just talk a little bit more about that? And yeah.
Yeah, that one would be really straightforward to the answer of the question which has been raised regarding the reassurance of how someone can be able to, how someone can know if he's doing a great job. That is an application called React. It's being used with Rumify, where you can connect, link it to someone and to share the image, your scanning technique. And from that, you can learn how to scan, but also to learn how to make a diagnosis and management. Also part of it, I would say that the ultrasound being non-invasive, of course, some of the procedures like a nerve block are invasive. So doing a scan and sharing the recorded image is one way of ensuring the quality assurance of and the competence of someone. So that's what I would advise. And there comes the role of collaborative efforts. Most of the people doing a POCUS and POCUS organization are very flexible and lovely to collaborate on sharing image for review on that purpose. So I would advise it to use like online application, also like to review someone's scanning capabilities and guide toward the future improvement. Thank you.
Thank you very much for those thoughts, Vincent. It looks like Mpundu, you can unmute yourself and give us your thoughts as well.
Yeah, just wanted to comment that in Zambia, POCUS training is actually part of the family medicine training program. And so the registrars are able to work with the trainers throughout the training period, which is 4 years. So this gives us enough time really to work alongside the medical trainer and gain the skills that are needed and the experience. And so far, the registrars are really appreciating it, and it's really making a difference in our clinical practice. Yeah.
That's excellent. That's really wonderful. It's great to hear that. I think eventually this is like in emergency medicine in North America and Europe, is going to be completely embedded in a requirement of residency training. But in internal medicine and family medicine and other specialties, there's, we're not there yet, but we're moving towards that. And so you're really fortunate to have that training in your residency there in Zambia. That's incredible. I love the sort of things that allow for scan review and for the bidirectional nature of tele-ultrasound and kind of mentorship. And I think that is such an equalizing empowerment educational tool, and to be able to reduce the footprint of the old way, like Dr. Strata was saying, and Dr. Ahmed, of just like sending people over. I don't know if, initially that, I think that's probably very important, but after that, it should be, I feel like, just a longitudinal training up and capacity building model to reduce kind of the old idea of what needs to happen with training, that have it be truly bidirectional. Along those lines and commitment to ultrasound education, I wanted to put a plug in our organization, Global Ultrasound Institute. If there's any residency or any medical school or any teaching hospital in lower middle income countries, they will be able to be freely sponsored for whatever for any of their residents or any of their learners there. So you can contact us for further information on that to get quality ultrasound education. So I think that we're at the end of our time. It's at the top of the hour. Thank you for all of the chats and the questions that we've had, and a really lively, excellent discussion. And most of all, thank you so much to the panelists, Dr. Strata, Dr. Belknap, Dr. Makasa, Dr. Ndebwanimana, Dr. Ahmed. Really, really great cases that are born of your personal experience. And thanks for sharing that for all of us today. And look forward to the next one. Thanks again to POCUS Certification Academy and Tori for giving us the opportunity.
Yeah, thank you, Dr. Bergman. Thank you for being facilitating the discussion today, and thank you from us to all of the panelists as well, and to you attendees for attending today. That does wrap up our session today. A recording of this webinar will be made available on the POCUS.org website in approximately 1 week. For more POCUS talks, check out our Focus on POCUS podcast, POCUS blog posts, and of course, follow us on social media where we post regular POCUS clinical challenges. Don't forget to check out our POCUS World Virtual Conference page at www.pocus.org. Thank you for attending our webinar today, and we look forward to seeing you on a future webinar.